Um, Hello everyone. Today our class deals with the gingival crevicular fluid, which is the also known as the oral sulcular fluid. So let's begin the class. So the sulcular fluid or gingival crevicular fluid has been known since the 19th century. So the pioneer work regarding the gingival crevicular fluid was done by Verhoeven, Brill and Kratz in the 1950s, and the composition and the possible role in defense mechanism was studied by them. So nowadays, the potential use of the gingival crevicular fluid as a diagnostic or prognostic biomarker of the biological state of the periodontium is also well known to each and every one of us, as it indicates the state of the periodontium, whether it is healthy or diseased. So the main route of the gingival fluid diffusion is through the basement membrane, that is through relatively wide intercellular spaces of the junctional epithelium, and then into the sulcular epithelium, then into the sulcus. So this was first studied by injecting dogs intramuscularly with fluorescein, and this fluorescein injected intramuscularly into the dogs was recovered using paper strips within just 3 minutes, which indicated the passage of fluid from bloodstream through the tissues and exiting via the gingival sulcus. So this proved that the fluid has a passage via the intercellular spaces of the junctional epithelium into the sulcus. So the value of the gingival fluid is either a transudate or an exudate. According to Brill, he described the crevicular fluid as a transudate, while many others explained it as an inflammatory exudate. So in healthy sulcus, the amount of gingival fluid is usually very small, and during inflammation, the gingival fluid flow increases, and here the composition starts to resemble that of an inflammatory exudate. So the main composition of the gingival crevicular fluid, it contains cellular components, organic ions, inorganic ions, enzymes, and bacterial products. So what are the cellular components? Cellular components mainly are composed of the neutrophils, then the lymphocytes, monocytes, and the epithelial cells. The cells which are desquamated from the epithelium. The organic ions includes the proteins, albumins, gamma globulins, and immunoglobulins. The inorganic content includes sodium, potassium, calcium, magnesium, and phosphates. The enzymes included here in the GCF are the acid phosphatase, alkaline phosphatase, cathepsin B and D, collagenase enzymes, elastase, lactates, dehydrogenases, lactoferrins, lysozyme enzymes, just to name a few. And the other also bacterial products are seen here. These includes endotoxin, trypsin-like enzymes, acid phosphatase, alkaline phosphatase, and prostaglandin-like products. So these are the main contents of the GCF. So it includes cellular components, organic and inorganic ions, enzymes, and bacterial products. And glucose, hexosamine, and hexuronic acid are the two of the organic compounds which are found in GCF. And also, it is found that the blood glucose concentration of GCF is usually 3 to 4 times greater than that in serum. Also, the total protein content is also much less than that of serum. So, coming to the immune mechanism of GCF, that is, it has both cellular and humoral activity. The analysis of GCF constituents in both health and disease is extremely useful because of its simplicity and because GCF can be obtained by using very non-invasive methods. So the GCF analysis has enabled all of us to identify the cell and humoral responses in both healthy individuals and those with periodontal disease. So also we find that the GCF contains contents like interleukin 1 alpha, 1 beta, and these interleukins are usually indicate that there is a process going on the process which causes release of lysosomal enzymes and stimulate bone resorption. So these interleukins are known to increase the binding of polymorphic nuclear neutrophils and monocytes and macrophages to endothelial cells and stimulate the production of prostaglandin E2. So also the GCF contains interferon alpha, which again is has the ability to inhibit the bone resorption activity of interleukin 1 beta. So we see the roles of various cytokines, and besides these, we also have leukocytes in the dentogingival junction. The main port of entry of leukocytes into the oral cavity is through the gingival sulcus. It is seen that that in clinically healthy normal human gingival sulci, almost 91.2 to 91.5% are composed of polymorphic nuclear neutrophils, and 8.5 to 8.8% consists of mononuclear cells. So they travel across the epithelium into the sulcus. So these among these mononuclear cells, 58% consists of B lymphocytes, 24% consists of T lymphocytes, and 18% constitute the mononuclear phagocytes. Usually the ratio of T lymphocytes to B lymphocytes is found to be reversed. That is, the normal ratio found in peripheral blood is 3:1, but in the GCF we find the ratio to be reversed. It is 1:3. That is, T lymphocytes is to B lymphocytes ratio is 1:3 in the gingival crevicular fluid. And the majority of cells are viable and they have the property of phagocytosis, and they help in killing any bacterial invasion which occurs within the gingival sulcus. So leukocytes constitute the major protective mechanism against the extension of plaque into the gingival sulcus. Now, also many drugs also find their passage into the gingival crevicular fluid, and this in turn can be used advantageously to treat periodontal patients. So extensive research has also been done in this regard, and it has been found that tetracyclines are found in large quantities in the gingival crevicular fluid, and also metronidazole has been detected in the gingival crevicular fluid. And it was found that many studies were done by Bader and Goldhaber regarding the concentration of tetracycline detected in GCF. And the clinical significance of a GCF is that it is an inflammatory exudate, and the amount of GCF is greater when inflammation is present, and is sometimes directly proportional to the severity of inflammation. Also, the amount of GCF increases during our normal masticatory process, especially when we take coarse foods, or also it increases in when there is a slight trauma induced at the site, like when you brush your teeth or when you give a gingival massage. Also, hormones affect the quantity of GCF produced, like ovulation, hormonal contraceptives, and also the GCF is found to be increased in smokers. So GCF production, however, is not found to be increased in trauma from occlusion. So this is a point to be noted. Other factors which influence the amount of GCF are the circadian rhythm, and it's also known as circadian periodicity, and also periodontal therapy. So this is a summary of the conditions where we find an increase in the gingival crevicular fluid. That is, a circadian periodicity shows an increase in the GCF. That is a time there is an increase in the production of GCF from 6 a.m. to 10 p.m. That is the time when we are normally awake, and there is a decrease afterwards. That is, during our sleep, the gingival crevicular fluid seems to decrease. And also, sex hormones contribute to increase in GCF. This could be mainly because of increased vascularity or vascular permeability that occurs during pregnancy, ovulation, and during the intake of hormonal contraceptives. And also, we have seen, as we have already seen, that mechanical stimulation causes an increase in GCF. And also in smokers, there is usually an immediate transient increase, but seen in the gingival crevicular fluid content. And also, there is an increase in the GCF content after periodontal surgery, that is post-therapy. So now let's go to the functions of the GCF. So the main functions of the GCF is to cleanse any foreign bodies or materials which are found in the gingival sulcus, and it also it's known to contain plasma proteins which help in improving the adhesion of the epithelium to the tooth, and also the GCF is known to produce antimicrobial properties and also to exert antibody activity to defend the gingiva. So these are the main functions of the gingival crevicular fluid. Now the formation of GCF was first described by Alfano, and here he described that in the absence of inflammation in subgingival plaque, the production is usually mediated by a passive diffusion of extracellular fluid by an osmotic gradient. So the fluid here produced is a transudate. And however, when an inflammatory response is provoked by compounds like microbes, or when there is a permeability of the epithelial barrier, underlying vasculature increases. That is, there is an increase in the blood supply, and GCF protein concentration is modulated by the extent of plasma protein exudation. So here, during inflammation, it naturally converts itself into an inflammatory exudate, and there is an increased production of GCF. So this is a picture depicting the GCF being produced and coming out through the crossing the epithelial barrier and coming out into the gingival sulcus. So now methods of collection, there are different methods whereby we can collect GCF. So some of the commonly used methods are use of absorbent paper strips, then free-weight twisted threads which could be placed into the gingival sulcus, which was first described by Weinstein et al. Then use of micropipettes, and also use of intracrevicular washing. So let's see how each method is performed. So now first technique is the absorption technique, that is use of paper strips. So here there are two methods again, an extracrevicular method and an intracrevicular method. Extracrevicular method was first described by Lowe and Home Pedersen, and here the paper strips are just placed over the gingival crevice. This is to reduce the trauma. And intracrevicular method, which is the more commonly used method, here again there are two subdivisions in this method. That is, there is a superficial method as well as a deep method. The superficial method is whereby the paper strip is inserted only up to the gingival margin, and the deep method is where the paper strip is inserted into the gingival sulcus. So this is a picture depicting the different methods. The first one is the extracrevicular method. The second and third shows the superficial method and the deep method in the third diagram. So you can see how the strip is being inserted into the gingival sulcus in the second picture, where it's only placed at the gingival margin. Now this is how the paper strips are inserted into the crevice, the gingival crevice. And these paper strips gradually get saturated. The filter paper strips gradually get saturated with the fluid. Now, this is the microcapillary technique, where a calibrated volumetric or non-calibrated microcapillary pipette with a known volume is used to collect the GCF by capillary action. Here again, the pipette is inserted into the gingival sulcus to collect the fluid. Another method is the intracrevicular washing technique. Here again, there are two methods. One is the open clean method, where a hard acrylic hard acrylic appliance is used to cover the maxilla with soft borders and a groove with a groove following the gingival margin. Here the crevicular areas will be rinsed using a peristaltic pump, and the crevicular washing which is obtained is then collected using 4 collecting tubes, and thereby the amount of crevicular washing collected is then assessed to know the amount of gingival crevicular fluid. Another method, which is a modification by Salonen, here they use 2 injection needles. If you can look at the diagram, you can see 2 injection needles fitted one with another. Here you see that one needle goes up to the gingival sulcus, which is used to pour saline into the gingival crevice, and the other needle is a collection needle, and this collection needle is uses a suction pump to collect the fluid into a test tube, whereby the sample is then examined. So, hope you can all see the two needles. One where the saline is used to wash the gingival crevice, and another tube placed near the gingival margin to collect the washings, crevicular washings. Now, how do we estimate the volume after collection? So, this the amount of fluid which is emanated can be estimated using by either weighing the strip or by measuring the capillary fill of the micropipettes. Another method is by measuring the volume of the crevicular washings. Another method is to measure the area of the filter paper which has been wetted, that is the distance to which the fluid has migrated can be measured. And this another method that is in order to get a more well-defined image of the amount that the fluid has penetrated in the filter paper, we can use a stain, that is ninhydrin can be used for staining the filter paper. Then another method, that is an electronic transducer, which has been of recent use, is the Periodon 8000, where they use a flow of electric current which will give a digital readout of the amount of gingival fluid collected. So these are the different methods whereby we can estimate the volume of fluid collected. So 3 models of Periodon have been introduced, that is since 1976. The latest Periodon is the Periodon 8000, which is of use at present. This is a picture showing the Periodon 8000. Here the main principle of measuring the amount of fluid is using the principle of a capacitor. That is, it measures the electric capacitance of a wet filter paper placed between the jaws of the instrument. So the instrument has a jaw wherein the filter paper is inserted, after which using the electric capacitance, you can measure the amount of fluid collected in the filter paper. So the translation of the Periodon values indicates the level of gingival inflammation and the gingival index. So Periodon reading of 0 to 20 indicates a healthy gingiva, wherein they assume that the gingival index is 0 in such cases. When the Periodon reading is 21 to 40, it indicates mild inflammation, and the gingival index is supposed to be 1. And when the Periodon reading is 41 to 80, it shows a moderate gingival inflammation with a gingival index of 2, and 81 to 200 indicates severe gingival inflammation with a gingival index of 3. So these are the Periodon values. So after which, now what could be the problems we encounter during the collection of gingival crevicular fluid? There could be like the sample obtained need not be purely the fluid that we require. It could be contaminated with plaque, saliva, or blood. And also the collection time has to be standardized. That is, the time for which the filter paper is inserted or the micropipette is inserted has to be standardized in order to enable comparison. And also volume has to be determined, because very small volumes are obtained. So it's very difficult to determine the amount of fluid obtained. And also it's very important to recover the strips, the fluid from the strips, because it could evaporate, the fluid could evaporate. So some discrepancies can occur in the measurements and also the data collection. So these are the problems usually encountered with the collection. So nowadays, since it utilizes a non-invasive approach, it can it shows a potential diagnostic role also. That is because it has a number of biomarkers which are indicative of the amount of periodontal disease. So it's very useful tool for the diagnosis of periodontitis in patients. So what are the potential biomarkers that we commonly come across in the GC? That is when we study the GC. They can be generally grouped into three categories. That is host-derived enzyme, inflammatory mediators and products, and tissue breakdown products. So they can be divided into three groups. So what are these host-derived enzymes and their inhibitors? They are the aspartate aminotransferase, alkaline phosphatase, acid phosphatase, beta glucuronidase, elastase, its inhibitors, alpha-2 macroglobulin, alpha-1 proteinase inhibitors, cathepsins, cysteine proteinase, serine proteinase, and cathepsin B. Now, coming to tissue breakdown products, these are glycosaminoglycans, hyaluronic acid, chondroitin 4-sulfate and 6-sulfate, dermatin sulfate, hydroxyproline, fibronectin fragments, connective tissue and bone protein, like osteonectin, osteocalcin, osteopontin, type 1 collagen peptide. And also the inflammatory mediators and host response modifiers include the cytokines, interleukin 1 alpha, 1 beta, 2, 6, 8, then human necrosis factor alpha, interferon alpha, leukotriene B4, prostaglandin E2, transferrin, lactoferrin, and immunoglobulins, which include G1, G2, G3, G4, and immunoglobulin M. So these are the different enzymes or tissue breakdown products and inflammatory mediators that are found in the gingival crevicular fluid. So let's go through some of the important and most diagnostically useful biomarkers. So coming to the first category, that is the host-derived enzymes. We usually use or estimate, or rather we can say estimate the amount of aspartate aminotransferase, because this is indicative of sites with active periodontitis, and it also is an indication of clinical attachment loss and inflammation. There is usually a marked increase of AST in patients with periodontitis. Another important biomarker is alkaline phosphatase, which is produced by leukocytes, macrophages, osteoblasts, and fibroblasts. It's again a potential biomarker for periodontitis. The other important host-derived enzymes include beta glucuronidase, which is one of the enzymes involved in the destruction of non-collagenous components of extracellular matrix and is considered an indicator or rather a predictor of periodontal disease activity. Another enzyme of importance is elastase, which is again released from the polymorphonuclear neutrophils and is considered to be a risk factor for periodontitis. And a few other enzymes include cathepsin B, which is a cysteine proteinase and again is released from macrophages and is an indicator of attachment loss and periodontitis. And one more enzyme which is of diagnostic value is the matrix metalloproteinases, which belongs to a family of zinc-containing enzymes, and they are responsible for degradation of extracellular matrix components such as collagen, proteoglycan, laminin, elastin, and fibronectin. Besides these, we also have leptin, which is involved in the host response. That is, it stimulates the immune system by enhancing pro-inflammatory cytokine production and phagocytosis by macrophages. So during gingival inflammation, the concentration of leptin is decreased as a result of expansion of vascular network, which is caused by vascular endothelial growth factor. Then coming to the inflammatory mediators and host response modifiers are mainly the cytokines, which are potentially useful diagnostic or prognostic markers of periodontal disease. Of these, most important ones are interleukin 1 beta, 4, and 8. So these regulate the cellular inflammatory response in the periodontium. So the presence of these indicates active periodontal disease. Also, substance P is which is localized in the sensory nerves and is known to innervate the blood vessels. It is correlated again with the degree of periodontal inflammation, and it's also it is found that when there is an effective periodontal treatment has been done, the amount of substance P gradually decreases in patients. So the decrease in substance P is again an indicator of improvement in the periodontal condition of the patient. So tumor necrosis factor alpha is again a pro-inflammatory cytokine that is usually seen in a periodontitis patient, which is indicative of bone resorption taking place in the patient. And monocyte chemoattractant protein, high levels of the MCPs have been reported both in case of aggressive periodontitis and in chronic periodontitis patients. And now coming to the tissue breakdown products, which includes laminin and osteopontin. Here, laminin usually is seen in periodontal pockets, is indicative of periodontitis, and osteopontin, that is increased level, is often seen in periodontitis, and there will be a reduction of the same, that is osteopontin in periodontal syrup. So the increase is indicative of active disease, and the decrease is indicative of effective periodontal syrup. So can be used both as a diagnostic tool as well as a prognostic tool. Osteocalcin. So here again, the increase reflects the the degree of inflammation at the disease site, and it's again a potential marker of bone turnover in periodontal disease. So we have gone through a number of biomarkers, and these biomarkers have been used in diagnostic kits, which is an aid to periodontal diagnosis recently. So a lot of improvement have been done in the field of research of these biomarkers, and these have helped us to diagnose periodontal disease, that is using chairside diagnostic kits. So these that is, we already know that periodontal disease can be diagnosed clinically and radiographically. So now precise molecular diagnostic methods and treatments have been introduced using these chairside kits. So what are the main advantages of these chairside kits? So the main advantages are, it's very simple to use, and it can be, that is, the readings can be made in a very relatively short period, and also it can be used as a tool of patient education, because we see a change in color or some diagnostic feature which can be shown to the patient, and the patient can be educated about the state of periodontitis of the patient. So let's see what these diagnostic kits are. So the main chairside kits available are the prognostic. This is mainly used for detection of serine proteinase elastase in the gingival crevicular fluid. And here the confirmative test indicates that is, it becomes visible under fluorescent light. Periocheck is another chairside kit. Here it's mainly used to detect the amount of neutral proteases in the gingival crevicular fluid. Here the presence of neutral protease, that is there is a color indicator present in the periocheck, and here the color changes into blue color, which indicates the presence of neutral proteases. Another chairside kit is the PerioGuard. Here it's used for detection of AST levels in the GCF. Here again there is a color code given, which will be given in the chairside kit. And again, a Perio watch is another kit which detects the AST levels in the gingival crevicular fluid. Here the green dye present in the Perio watch kit turns into colorless, which is indicative of the presence of AST in the sample tape. So these can be used effectively to educate the patient as well as to diagnose the disease condition, and the extent of the amount of AST is again indicated by the change in the color, which in turn helps us to determine the presence or absence of periodontal disease as well as the extent to which the disease is present in the patient. So let's come to the conclusion. So we have gone through a series of steps, that is from the collection of GCF to its utility, that is to its utility as a diagnostic and prognostic marker. So future therapeutic approaches may be directed at stimulating more components of GCF, that is, more components are yet to be found out, and there are ample possibilities for future use of these oral fluids in biotechnology as well as healthcare applications, and especially in the field of periodiagnosis. So let's hope for more researches and newer information about the gingival crevicular fluid, and let's make use of the present available kits to enable us to get more accurate and better diagnostic approaches for periodontics. So we come to the end of this session. Thanks.